Okay, our next speaker is Dr. Rob Sonnenburg. He also serves on our Wisconsin Sleep Society board, and I'll let him tell you a little bit about himself. Thank you.
Thanks, Marla.
Yeah.
Thanks, everyone, for having me here to give this presentation today. This is my first year being on the board for the Wisconsin Sleep Society, and I've really appreciated working with the other board members and all the work that they've put into this meeting, and also appreciate everyone who's here in person and also the individuals who are joining us virtually on the Zoom meeting. I'm a otolaryngologist. I'm also board certified in sleep medicine, and I practice in Green Bay at Aurora Bay Care Medical Center. And I'm going to be talking specifically today about hypoglossal nerve stimulation. Alex has given you kind of the wide view of alternative treatment options for obstructive sleep apnea other than CPAP, and now we're going to really focus in on this one treatment option. I also have no financial disclosures. I do use the Inspire device. It's currently the only FDA-approved device in the United States. I am, however, using some of the slides provided for Inspire for this presentation. And there are 3 companies worldwide that make hypoglossal nerve stimulator devices. Inspire. Nyxoah is the name of the company that makes the Genio device that you saw earlier. That has 2 components. That inserted component placed through a single incision that stimulates the hypoglossal nerve bilaterally. And then there's that external component, that kind of knob that is taped to the skin at night that people use. And then LivaNova is another company that produces a device that's used over in Europe. In terms of the goals that I have for this talk, we're going to do a little pre-test. We'll talk about the background of neurostimulation for the treatment of obstructive sleep apnea, look at some clinical data from a couple of studies. And then I want to talk about candidacy, look at what a drug-induced sleep endoscopy looks like. You hear about that when we're evaluating patients for this procedure, just to show you what we're seeing and looking for with that procedure. And then talk a little bit in detail about the implantation process, the surgical anatomy, some of the risks that are involved, and then some of the things that are on the horizon with neurostimulation for obstructive sleep apnea. Okay, so these are just questions for everybody to read and think about. Maybe you know the answers already, maybe you don't, but hopefully these are things by the end of our talk that you will know the answers to. So what year was it noted that genioglosal activation correlated with upper airway patency? It's kind of the birth of the idea for using neurostimulation for obstructive sleep apnea. And then how long did it take from that observation till it was clinically available outside the research arena in the United States? How does it compare roughly with PAP therapy for reducing the apnea-hypopnea index, changing the Epworth Sleepiness Scale scores, and what does compliance look like? What are age, BMI, AHI, DICE, drug-induced sleep endoscopy, and PAP trial criteria for a person to be a candidate for this? If your patient's implanted, can they have an MRI? It's kind of a practical one. And what are some of the risks of the surgery? And in terms of why we're talking about this and the problem, as everybody here knows who's treating people with obstructive sleep apnea, we have this really effective treatment for it. Lots of data, like Alex showed, about its effectiveness for all sorts of beneficial things, decreasing hypertension, safer driving, reducing your risk of recurrence of atrial fibrillation. And for many, many of the patients, it's very well tolerated. And so we've got this great treatment, but it's not tolerated by everybody. And here's a study. This is old. This is almost 20 years old now. But this was a study that individuals that came to a sleep clinic were prescribed CPAP, and they were called by a nurse a year after their CPAP was prescribed to say, are you using it? And in this study, only 50% of people were. Not that that's your practice. In 20 years, I think there have been a lot of things in CPAP that compliance is better than this. But certainly I think we can all agree there are some patients that despite their best efforts and our best efforts, they're just not using the treatment regularly. So what do we do? A lot of people in this room spend a lot of time on 1 and 2, educating patients about the importance of it, making sure that they have they're placing the mask appropriately, encouraging them, desensitization protocols, things like that, changing settings, maybe using ramping, expiratory pressure relief, bi-level pressure settings, humidification, trying different mask interfaces. As an otolaryngologist, treating nasal obstruction is still a very big part of my practice for patients with obstructive sleep apnea, and I would say probably still the most common surgical types of procedures that I do for individuals with obstructive sleep apnea, not with the goal of curing their sleep apnea, but hopefully getting them to be able to tolerate their CPAP better or possibly an oral appliance. Oral appliances, Alex touched on that, and we're going to hear a presentation from Dr. Taché also later that'll discuss that. And then let's talk about surgery in general. So here's a list of surgical procedures that otolaryngologists or oral surgeons might do for this. When I trained, one of my professors liked to say, the more procedures there are for something, the less effective that it is. And certainly there are many different phenotypes for obstructive sleep apnea and upper airway anatomy. And so multiple procedures have been developed to try to address some of those different things. But it's wanting. We have procedures that are very effective, like a tracheostomy or maxillomandibular advancement, but often patients don't want to have it because of the morbidities associated with those procedures. And then we have other procedures like uveolopalatal that if you look at its success rate in unselected patients, pretty poor. Patient selection becomes extremely important and in their anatomy. And like Alex showed in some of his slides, I use that Friedman staging in my practice, and you really want to see a patient who has a relatively low modified Malan-Patty score, large tonsils to be a good candidate for this, but always there's the possibility of having retrolingual obstruction, and so possibly needing additional procedures for it. And really, besides tracheostomy, which is a bypass procedure, you just get around the problem, all of these other procedures are static procedures to enlarge the size of the airway. And, it kind of makes sense to patients. They come in and they say, oh yeah, my doctor told me I have a small airway, so I have this problem. But it's a lot more complicated than that. If you had a small airway that stayed open all the time, it would be okay. And these patients who walk in and say, I have a small airway, but they're awake and they're breathing fine. And so we're kind of addressing the size of the airway, but not necessarily some of the underlying problems. So I always smile a little bit when patients come in the office and they're like, hey, I heard there's something new, and I'm interested in that. And the beginnings of this are not very new. So here's the answer to our first question. Upper airway patency is strongly correlated with activation of the genioglossus muscle. I think that was seen in a CAP model, 1978. And this is really the birth of the ideas of neurostimulation for treatment of obstructive sleep apnea, and the thought, hey, maybe if we stimulate the hypoglossal nerve, that activates the genioglossus muscle, that will help us to maintain upper airway patency. And so I think in the late 70s, sleep labs were opening, people were starting to think about this. At the time, the only treatment really was a tracheostomy or weight loss, and which was a major impediment. And so this was an exciting idea. And I know not everybody thinks necessarily about these muscles all the time, so I put a couple slides in just to look at muscles that we're talking about here. Will this show up on here? Yeah, so this is the genioglossus muscle that inserts on the inner surface of the mandible and then into the tongue itself. And it is a tongue protruder, the main tongue protruder, and a very large muscle. The genial hyoid muscle sits below it, which goes between the hyoid and the mandible, and that brings the hyoid bone forward, again, kind of opening the airway from front to back. And then there are muscles that retract the tongue or move the tongue to the side. Extrinsic muscles, the styloglossus, stylohyoid, and hyoglossus muscles do that. Additionally, there are intrinsic tongue muscles, muscle fibers that just run within the tongue. And those include the transverse and vertical fibers and the longitudinal fibers. They flatten the tongue, stiffen the tongue. For people who can kind of curl their tongue, the intrinsic muscles do that. And so in the late 70s, this became a point of interest. Maybe this is going to be another treatment option, the next great thing. And then this guy returned, this is Colin Sullivan, who returned from a research fellowship at University of Toronto back to Australia. He was interested in sudden infant death syndrome and the neural regulation of breathing during sleep, and worked with someone at University of Toronto who was using PAP therapy in pugs and boxers, and thought, hey, maybe this would work with people. Let's try it. So that's, I believe, 1983, and sure enough, it worked. It was great. And I think because of that, now there was a very effective, non-invasive treatment for obstructive sleep apnea. Neuromodulation kind of got put on the back burner, and it was quite a while before we saw significant work continue in here. Now here's one, 1993. So in 78, they said, oh, if we put an EMG needle in the genioglosal muscle, we see that when that muscle's activated, airway patency is better. Here's stimulating the hypoglossal nerve to prove. If you have this was a cat model with inspiratory flow limitation, and they purposely stimulated the hypoglossal nerve to show, yes, that does open the airway up. But it was from 93 until 2011 when it was done in human subjects. 2011, 18 patients were implanted with a hypoglossal nerve stimulator, and 12 of those 18 patients showed significant improvement. And so it kind of moved along, but answer to question 2 from identifying, hey, this correlates with upper airway patency, maybe this is going to be a good treatment option, to actually getting into some clinical practice over 30 years. Okay, and so this is kind of where we are today with hypoglossal nerve stimulation. And you can see what we want to do is find this hypoglossal nerve. It has individual branches, some going to those muscles that retract the tongue, some going to the muscles that protrude the tongue. We want to place the stimulating cuff on the branches that are the tongue muscle protruders. Okay, and this is just a little video that I'm going to show you. So on the left side, we're looking at an airway with no stimulation, and this is trying to represent that the tongue muscles are relaxed and the tongue has fallen backwards against the posterior pharyngeal wall. And on the right side, we're going to see that the tongue muscles the tongue is protruded slightly. This is kind of a mild stimulation, and we're starting to see the airway open. And let me see if I can get this going. So if you are looking endoscopically in a person who's sleeping here, thanks, Alex, we're seeing base of the tongue, lateral pharyngeal walls, and as the person's breathing in, you're seeing a collapse of the airway, a narrowing of the airway. This video shows similar thing. This is looking at the back of the palate, so you're kind of like you're in the nasopharynx at the posterior nasal cavity, and you're looking in the palate, retropalatal airway looks completely collapsed. In these videos, we're seeing some mild stimulation, so you're still seeing a tendency for that base of tongue and lateral pharyngeal walls to collapse, but now with the stimulation, it's kind of popping open. And similarly, when we look at the palatal level, same kind of thing. It's collapsing and closing, but with the stimulation, you're seeing the airway start to pop open. And this is something that there's a dose-response curve to it, that as you increase stimulation level, you can get more and increase the protrusion of the tongue. you can get more and more opening of the airway. So here, these little red lines are kind of marking the area of the airway with no stimulation, a very low stimulation where person's first like sensing something, where you first start seeing some movement of the tongue, and then when the airway is opening up more widely. And one of the interesting things about this, I think, is we're stimulating the tongue muscles, we're moving the tongue, but we are seeing improvement also at the level of the palate with this stimulation. The palatal muscle connects the palate to the tongue, and we think that that's why we see palatal opening as well. And then what we'd like to see, here's an ideal situation, looking at your polysomnogram in a person who's having regular obstructive events on the left-hand side, persistent respiratory effort, and this oxygen desaturations, and that when we activate the stimulation, open the airway, we see normalization of those parameters. Okay, so that's just a little bit about neuromodulation and kind of how this works. Now we'll look at a little bit of information, clinical information about it. The STAR trial was a trial published in the New England Journal of Medicine in 2014, and that was the year that hypoglossal nerve stimulation and Inspire were FDA approved. In this study, it was a multi-center study between centers in the United States and Germany, prospective single group cohort design. 126 patients were implanted, and the average reduction in the apnea-hypopnea index was 68%. They saw improvements in the functional outcome of sleep questionnaire and improvements in Epworth Sleepiness Scale scores, as well as a decrease in the median time with an oxygen desaturation less than 90%. And so, here's one of the things when we're comparing PAP therapy to hypoglossal nerve stimulation that I think it's important for people to know is that it hasn't been shown to be better than CPAP. CPAP is still our first-line treatment. It's still what I recommend to all my sleep apnea patients if they haven't tried it. It is quite common for me to have patients come to my office and say, hey, I saw this on Facebook, or I saw a TV commercial. I don't like bringing my CPAP machine through the airport when we go to Florida. Tell me about this. And I look at their download and their compliance is excellent. And I say, hey, I think you're better off doing what you're doing. Stay with this. Because, as you guys also know, looking at downloads, when you have your compliant patients who are doing well with therapy, you're usually getting a much greater than 68% decrease in their apnea-hypopnea index. And it's something that I think it's really important for patients to know. Like Alex said, when you have patients, though, who, again, despite their best efforts, our best efforts, are not using it or can't use it, I think this is much better than no treatment. Okay, now this is information also, some from the STAR trial, but then some additional studies that were published at 3 years and 5 years, looking at some numbers. In the STAR trial, the baseline apnea-hypopnea index was 29. At a year, it was 9 with therapy, and it's a durable response. So people who continue to use their device continue to have improvement in the apnea-hypopnea index at 3 years and 5 years. We also saw improvement in the Epworth Sleepiness Scale, and that also was a durable response, that at 1 year, 3 year, and 5 years, there's improvements. And so the STAR trial, those numbers, when patients ask me, those are the numbers that I usually quote to people, but there certainly has been a lot of data and studies and looking at this over the last several years, over 100 publications now in the medical literature about it, the 3 and 5 year follow-up data, the single centers that were involved in the multi-center trial have published their individual results, both in the United States and Germany. There's a study, a feasibility trial that's been done with individuals with Down syndrome. The ADHERE registry has been started. That's something run by Inspire. I'll talk about that a little bit more in upcoming slides here. And there have been studies that have compared upper airway stimulation to other upper airway surgeries and compared them. So the ADHERE registry, this is an international multi-center registry. They have a goal of enrolling 5,000 patients. A couple of years ago, they were right around 2,000 patients that meet the usual criteria for hypoglossal nerve stimulation. Here's some of the characteristics of the individuals when they had around 1,000 patients in terms of their age, gender, ethnicity, body mass index, apnea-hypopnea index, and some of their baseline comorbidities. We keep information's being collected for the ADHERE registry on side effects and complications, serious things like a tongue weakness, need for removal or patient requiring a removal, and then other things too, like getting an abrasion on the tongue, discomfort at their incision or device site. So that information's being collected and looked at, and as implantation numbers go up, we're getting more accurate ideas of what to tell patients of things that they can expect. When you look at patient satisfaction and also the satisfaction of the physicians who are prescribing the treatment or recommending this for patients, we're seeing really good numbers for that. I mean, that's been my anecdotal clinical experience, that most people have been very happy with this as a treatment option. It's something that they find relatively easy to get acclimated to and use. It's very common for me to see patients, not everybody, but many of the patients who are implanted, when they come back, they're using it 90% greater than 4 hours a night. They're using it for 5, 6, 8 hours a night. So from a compliance standpoint, I've been really pleased with what I've seen personally, and that's borne out in other studies as well. This is something that kind of looks at and compares a couple of CPAP trials and compliance, reported compliance in those trials, and to what currently we have with the ADHERE registry. So doing better around 6 hours a night. So just a quick summary of a little bit of that clinical evidence. You know, there have been consistent evidence of therapy effects in multiple trials, over 100 peer-reviewed trials. Looks like outcomes are long-term, at least if you call 5 years long-term. Adherence seems to be very good. And when we compare this to some of the other surgeries that I do, I'm happy with the outcomes that we're seeing. Okay. Next, I want to talk about just candidacy, and I'm sure especially sleep techs, you're seeing people, you're doing sleep studies, and they're saying, hey, you know, oftentimes you guys are like on the front line of patients' questions with this. So it's FDA approved for adults age 18. Some insurance companies still are sticking to 22, but most of them are accepting 18. Moderate to severe sleep apnea, that is, we're defining as an apnea-hypopnea index between 15 and 65. And you want to see less than 25% of those are central or mixed apneas. Unable to or unwilling to continue with CPAP usage. Body mass index, like Alex said, Medicare, it's less than 35. Still a couple of insurance companies hold on to the 32. And then we want to see a lack of complete concentric palate collapse on a drug-induced sleep endoscopy. So if you're not an otolaryngologist, that might not be as familiar a view or a look at the anatomy. So I wanted to talk about that a little bit. So drug-induced sleep endoscopy is something I have to do for every patient that I'm considering for hypoglossal nerve stimulation. Personally, I do it every patient that I do upper airway surgery for sleep apnea, except children. I usually don't do it in kids who are getting their tonsils out. But if I have a patient that I'm going to do a uvulopalatal pharyngoplasty or high mandibular suspension, I do a drug-induced sleep endoscopy on them as well. So the kind of protocol that I use for this, we give patients Robenal to dry up their oral secretions, bring them back to the operating room. You have to work closely with anesthesia with this. You want them to drift off to sleep, where they start snoring, start having some pauses. You don't want to give them a big bolus of propofol where they, you know, nobody's going to take a breath. It's a central apnea. and now they're desaturating and you're having to mask ventilate them or intubate them or place an LMA. And so we usually start at 100 mics per kilogram per minute and increase that about 25 mics per kg per minute every few minutes until we start to hear snoring, they're not responding to the voice, and don't respond to me putting an endoscope in their nose. Okay, so this is kind of the anatomy we're thinking about when we're doing our drug-induced sleep endoscopy. On the left is a sagittal view. You know, we're going in the front of the nose, and we're seeing the turbinates, the septum, and we want to get to the back of the nose, where the nose empties into the pharynx, what's called the nasopharynx. In the nasal cavity itself, we have the hard palate underneath us, but as we get into the nasopharynx, we have the soft palate. And the middle picture is showing the front of the nose, so you see the nasal septum on the left, the inferior turbinate directly on the right, and then the middle turbinate upper right. And we're going to go past that into this kind of dark area right here to get to the nasopharynx. In the nasopharynx, this is the posterior aspect of the nasal septum. This is the eustachian tube orifice here. Adenoids would be here. Down here is the soft palate. And that's the level that we're looking at when we do these endoscopies. I'm going to bear with me for just a second. I'm going to leave my PowerPoint presentation to show you a video. And first I'm going to show you a video that I classified as an anterior-posterior collapse pattern and a person who would be a good candidate for Inspire. Okay. Oh, here we go. Okay, so here we are in this view in the nasopharynx. So again, this is the posterior septum here, eustachian tube orifice here, posterior nasopharyngeal wall, and here's the palate. And this is what we want to see, that the palate is predominantly moving in this front to back direction. And I don't have sound on this video, but this person's snoring. And so you're kind of getting a sound with this. And then in just a second, I'm also going to look lower, and I do this also routinely to look at the base of the tongue, lingual tonsil, epiglottis, and also see the lateral pharyngeal walls. And so here we're starting to go down a little bit. We're going to slide past the uvula on the left there. And then what we're seeing here, this is lingual tonsil, posterior back of the tongue. And we see a significant narrowing here between the back of the tongue and the posterior pharyngeal wall. Really, it's hard to see this person's larynx, epiglottis. But those are retinoids right down there, just a peak of them, and the glottal opening is right about here, where my arrow is. Here we go. Here's epiglottis, and then glottis is down there. So this individual has a predominantly front to back collapse pattern. A person who I think would be a good candidate for something at the base of the tongue. This person probably be a pretty decent candidate for an oral appliance, but a good candidate for hypoglossal nerve stimulation. And then I'm going to show you a video of someone who has complete concentric collapse and would not be a good candidate. I'm going to advance this a little bit. Okay. So here, same view. I'm a little bit closer, and one of the things that you find when you start doing these is there can be really a significant difference in the depth of the nasopharynx. In that first video, that was a nice wide front to back nasopharynx where you could be farther back and see the palate. And this individual had a very shallow nasopharynx. And what we're seeing here is a lot more lateral collapse. So we're kind of seeing at least equal AP and lateral collapse, and things are just kind of coming together concentrically. These were individuals who did not get good results with hypoglossal nerve stimulation, and it is not indicated in someone who has that. Okay. Okay, So that's candidacy. You know, that's what we're looking for. Currently, adults, body mass index less than 35, apnea hypopnea index between 15 and 65, less than 25% central apneas. They've at least tried CPAP and given it a real try and are unable to consistently use it. And then we do this drug-induced sleep endoscopy and make sure that they have the right pattern of collapse. So now I'm going to talk a little bit about the implant process itself and what this looks like in surgery. So this is done general anesthesia. I usually ask anesthesia to intubate the patient through the nose to do a nasotracheal intubation, just to have it easy for me to see the tongue movement when we get to the point where we're testing the device. Surgical landmarks here. We mark out the inferior border of the mandible, the hyoid bone, mark out the external jugular vein. The reason for that is we're going to tunnel the stimulation lead underneath the skin, and you don't want to tunnel it through the external jugular vein. And then the incision is halfway between the hyoid bone and the inferior border of the mandible. And if there's any otolaryngologists in the crowd or otolaryngologists in the Zoom meeting, you know, think about your submandibular gland incision that is going to be a little bit more anterior and a little bit higher than you would normally do for that. But this is anatomy that any of your otolaryngologists who do neck dissections, submandibular gland excisions are going to be extremely familiar and comfortable with, anatomy that they're going to be very comfortable with. Usually we make the incision about 5 centimeters in size and start at about 1 centimeter lateral to the midline, sometimes a little bit farther back. My typical incision is probably a little bit lower than what's demonstrated on this slide. And then for our chest incision, this is anatomy that your practicing otolaryngologists might not be as familiar with. They've done it when they've done pec major flap reconstructions for head and neck cancer, but might need a little bit of a refresher with this anatomy. So our anatomy here that's pertinent for making our incision is the clavicle. We mark out the clavicle, and then you feel the first, second, and third ribs. And you want to place your sensing lead between the second and third rib, which for me tends to be about 3 finger breadths below most people's clavicles. Now, when I started doing this, when Inspire, initially people were doing 3 incisions. And so there was a cervical incision, there was this incision that was for the generator, and then we were doing a 3rd incision down at the side, kind of just below the pec major muscle. And that's where the sensing lead was being placed. It's been probably a couple years, I think, since the 2 incision has really taken off. It's way better. When we did the 3 incision technique, the external and internal intercostal muscles, they just seemed thicker down there. You had to deal with the serratus anterior muscle. It seemed like most of their discomfort, most of the complaints I got postoperatively were about that incision. And for women, putting that incision somewhere where it didn't cross where their bra was, like, is it inside there, is it underneath there? I mean, it really was a challenge. With this incision, it's cut down on operative time. You only have 2 incisions, so it doesn't hurt as much. The muscles are much thinner in that location. And likewise, because I think of the thinness of the muscle, the sensing lead signals are fantastic. I mean, they're really good, and I've really been happy with that modification of it. Other things to think about with this incision is what people like to do and making sure that you are not placing their generator right where they hold their 30-06 when they go deer hunting in Wisconsin, or people who like to backpack where the strap is and things like that are things to think about. You know, a lot of times I always ask patients about that if they hunt or shoot trap or things like that, and make sure that we're leaving plenty of room, that's not going to be an issue for them. Can be an issue with this. It was a much bigger issue with the 3 incision technique, is implanting patients who have breast implants. Similarly, you really don't want to do this and pop their breast implant, and then they have to have that replaced. With the 3-incision technique, the tunneling had to sometimes be a little bit more creative. With the 2-incision technique, I haven't had any problems with it. Okay, so that's kind of our incision technique planning. Then once we're getting ready to go, we do put these little needle electrodes in the tongue muscles. We have a needle electrode that we put in the hypoglossal muscle, and that's the red one. You put that about 4 centimeters back from the tip of the tongue, real superficial. They're showing in this picture, you want to see the prongs of that electrode, like right underneath the mucosa. Just below that villiform papillae junction where the mucosa looks smooth. And then when you place your genioglosal electrode, you want to put that lateral to Wharton's duct for the submandibular duct, and also the little openings for the sublingual duct that are in the floor of the mouth, and right into the genioglosal muscle. Again, this is something that your otolaryngologists haven't probably done a whole lot of because they have never really needed to do it for other procedures, but is pretty easy to do. And then we do a standard skin prep. Unlike a lot of procedures that otolaryngologists do, like tonsillectomy, where it's a clean procedure but not a sterile procedure. Sterility is extremely important for this procedure because we're putting a foreign body, or we're inserting a foreign body. And so similar to what they're doing with their neck dissections and things like that, they're going to use a similar technique for that. Okay. And then next we're going to look at the hypoglossal nerve and some of the variable anatomy of the nerve. And this is something, to be honest, for myself as an otolaryngologist and the neck surgery that I had always done, mostly neck dissections, submandibular gland excisions, thyroglossal duct cysts, that kind of stuff. You just found the nerve and then you stayed away from it. You're like, oh, there's the nerve and I'm going to leave that alone. And it was actually a real eye-opener for me when I started doing this. Actually, when I saw the very first one of the fascicular nature of this nerve and how much dissection you can do to this nerve to tease out these different branches that are there. You just like initially look at it and like, that's a bad idea. Well, I don't want to do that. I'm definitely going to get a nerve weakness, but it's pretty impressive to me what this nerve will tolerate and what you can find when you start to do the dissection. So the anatomy is variable. Here are 6, 7 nerves that show different branching patterns, but there are some consistencies that we see with this. And this is why those electrodes are in. And we've got a contingency from Inspire in the back row. When I do these cases, one of them's always with me, and they are watching the nerve monitor, giving me feedback about what they're seeing when I do stimulation of these different branches. And as I'm looking, I do these with a microscope, and I'm looking at these branches and seeing what I think are the correct branches that we want to be stimulating, and then I'm confirming that with them with what we're seeing with our monitoring on the nerve monitor. So we're gonna hone in on one of these nerves. This is a really nice example of what you want to see with hypoglossal nerve anatomy. And so what we're seeing here, there's that standard 5 centimeter incision. You go down, you find the anterior border of the submandibular gland, you retract that posteriorly. I palpate the hyoid bone, dissect straight down to it, and you'll see the digastric tendon, reflect that inferiorly. Bring the mylohyoid muscle anteriorly, and it opens this space. Now, this nerve always has a large vein associated with it called the renin vein, and that vein has been ligated in this example. We generally don't ligate the renin vein. I have a picture with a stimulating cuff where it's left intact, but sometimes you have to. But early on, people were pretty routinely ligating that vein. I think most implanters now try to avoid it, just with the thought if you ligate the vein, it's the venous drainage of this area. Potentially that's causing some venous congestion and more inflammation in the nerve. But what we see here in this nerve, several branches that are arising, and this is pretty far proximally, that are heading superiorly. And this is the typical location of exclusion branches, branches that go to the hyoglossus muscle, styloglossus muscle, stylohyoid muscle. And this would be fantastic if those were the only branches, because you'd have a nice big pocket for placing your stimulating cuff. If you look inferiorly at this nerve, this branch, C1, you'll identify that in most patients. Sometimes it comes off so proximally you don't see it. But this goes to the geniohyoid muscle, and this is a branch that we generally try to include in the stimulating cuff. We have these branches here, which are going to the genioglossal muscle itself. That's a large extrinsic muscle. That's one of the main protrusors of the tongue. And then there's something called the TV bundle. So these nerve branches are going to those intrinsic muscles of the tongue that stiffen the nerve. Now, this arrow, what this blue arrow is showing here, is that this individual has what's called the late hypoglossal branch. So this is a branch that is an exclusion branch. It's going to the hyoglossus muscle, in a branch that you do not want to include in your stimulating cuff. He's not playing nicely. He's not going along with the rest of these that are doing this. I think in this example, we're also seeing a small branch here. And that is not that uncommon of a finding, to have like a small late hypoglossal branch that arises on the posterior aspect of the nerve. You can include those in the stimulating cuff, and you can overpower it by turning your stimulation levels higher, but it's better to not. If you do that, you're stimulating both protrusor and retractor branches, and so you're getting this kind of push-pull. Interestingly, in the STAR trial that I quoted earlier, they did that all the time. They were placing the stimulating cuff on the main trunk, and so they were not necessarily dissecting out these what we now consider exclusion branches. And I think maybe some of the results that we see there compared to some newer studies reflect that more selective stimulation of the hypoglossal nerve is leading to some better results. So here's an example of a cuff that I've placed. So I've kind of gotten those inclusion branches together. This is what the stimulating cuff looks like. Here's the renin vein just inferior to it. The stimulating cuff has 3 electrodes. That's a kind of a built-in safety thing, that if one electrode breaks or stops working, you have 2 other ones that you can use. And it also allows us to try different stimulation protocols of the nerve, different ways to stimulate the nerve to see if that results in better tongue movement. Okay, a couple of pictures of chest wall anatomy. So, we've made our chest wall incision. We go down to the fascia, the pectoralis major muscle. That's where we're going to suture our generator to. We divide those muscles parallel to the muscle fibers, so you don't have to cut the muscle fibers, you just spread them apart. I think my next slide shows when you do that. Here's just a cartoon. People have this real thin layer of fat called the subpectoral fat pad underneath there. And once you swipe that fat away, you'll see the pectoralis minor muscle, and then you'll see the external and internal intercostal muscles. And I don't know how well it shows up on this slide, but the external intercostal muscles go the same direction of if you're putting your hands in your pockets, and the internal intercostal muscles go the opposite direction. And so you'll see this kind of shiny white fascia that runs in that direction for the external intercostal muscle, and in the opposite direction for the internal intercostal muscle. We want to go between the 2nd and 3rd rib and get in between the space. Here's an intraoperative picture. This is a little bit of subpectoral fat. The pec major is reflected away. These fibers are external intercostal fibers, and I take a spread here and expose some internal intercostal fibers. And that's the space that we want the sensing lead to go into. Okay, this is what the sensing lead looks like. Really important for people who are implanting that they're careful with where they grab this. These wires would be very easy to break if you grabbed them. So there's a grip zone here that's built into the sensing lead, which is where you want to grasp the sensing lead. And then you just insert it in between those 2 muscle layers. And once it's inserted, you anchor it down with some sutures. We anchor it down at the fascia, the external intercostal muscle, and then that lead comes up through the pectoralis major fibers, and we suture it to the fascia, the pectoralis major muscle, and then we create a pocket to place the generator, and we place the leads into the generator. So the one that's already in the chest, the sensing lead is always easy. The stimulating cuff that's in the neck, we tunnel through the subcutaneous tissue to bring it into the neck wound and insert that, making sure that it's inserted fully past the sealing rings. And then the generator itself, this is what they look like. It has a couple of spaces in the silastic housing for a couple sutures to hold it to the pectoralis major fascia, and that's inserted in a subcutaneous pocket. Really want to be careful when you do this insertion that you keep the wires behind the implant, because in 10 years you're going to have to come back and replace the battery, and you don't want to accidentally cut one of the leads. A pressure dressing's placed. I do this as an outpatient procedure. Typically these take about 2 hours or so for people to have done. We test the device once it's placed and then turn it off because we'll activate it in the office. Routine follow-up, they come back in a week with my nurse practitioner, Katie, who's sitting right there and seeing all these people for me, for a wound check. I see them back in the office at 4 weeks where we activate the device. We do some testing. We see where the patient feels the stimulation. Maybe some of you guys are doing this in your offices too already. And then we want to see tongue movement. And then we give the patient their remote control with the ability to increase their stimulation level at home. Usually they follow up with me sometime between 1 and 2 months, depending on how they're doing. Once we get to where they're noticing clinical effect, we usually do our postoperative sleep study and titration, which for most people it's about 2 to 3 months after their implantation. Okay, complications. So here are things that I talk to patients about when they're coming in and they've decided that they want to do this. So one of the things I think it's really important for patients to know is that this may not cure their sleep apnea. It probably won't. If we get a 68% reduction, we're hopefully getting more than that, but there still may be snoring. Their spouse may still see some apneic events. We're trying to reduce it, but we may not reduce it as much as they would like or I would like. Tongue paresis or paralysis, that's a risk. That would be serious, especially a tongue paralysis. That would affect everyday speaking and swallowing. That'd be a very serious risk. I've not seen that or had that, but it's possible with any of these procedures that you do. Interestingly, in the STAR trial, 18% of patients reported some tongue weakness afterwards. I think that's much lower now, but that's what was reported. You have to be careful about the marginal mandibular branch of the facial nerve where it crosses the submandibular gland. I think it'd be highly unlikely to cut it, but you could get, as you retract the submandibular gland, posteriorly and superiorly could get a traction injury. Pneumothorax, possible with placing the sensing lead. Again, not a complication that I've seen, but would be possible. Device malfunction, I have seen that. I've implanted 75, 73, something like that. 77, okay, people. And I've had one patient about 6 months after I implanted him, one of the wires, his sensing lead broke, and he had to have another procedure to have it replaced. So that can happen. Wound infection, fortunately I've not seen that, but that has happened where patients have had to be explanted. Blood loss, that is a risk with any surgery, is scarring, pain. Blood loss has been minimal with these procedures. I guess it could be, but. And then discomfort with activation, that is a possibility, especially if we're using a higher stimulation level. Patient might notice pain with that. Other considerations. MRI compatibility issues, this is a big one that patients have questions about. The original Inspire implant you could not have an MRI with. The current one, the 3028 model, is an MRI conditional device. You can have an MRI with a 1.5 Tesla magnet, but cannot have an MRI of your trunk. So head, neck, arms, legs, you can have an MRI. When we implant patients, we give them a medical device card they use at the airport. It also has a phone number on the back of it that radiology can call to get the technical information about that. Battery replacement, patients have to be aware that this runs on a battery. Battery life is good for about 10 years, but after 10 years, they're gonna need another procedure to replace the battery. Hopefully, in that 10 years, we'll be putting in a new device that's fully MRI compatible, but we'll wait and see what happens with that. Welding, electric cautery, electrical shock could short circuit the device. I have implanted 2 electricians, but they know that if they got really shocked that it could short circuit their device. I've talked to a couple of welders who've decided not to do it because same thing, arc welding could damage the device. In terms of long-term effect of repetitive nerve stimulation, to date, there have been no adverse effects noted for that. It's not like you're doing arm curls with one arm and not the other, that one side of the tongue gets bigger and the other doesn't, but we don't know 20, 30, 40 years down the road what will happen with that. And then managing patient expectations, that again, just like everything that we do, all treatments that we do, because this is relatively new, I spend a lot of time talking to people just about what this can do, can't do, explaining to my insomnia patients that this is not necessarily going to help their insomnia, even though they may have talked to someone who said they turned it on and they slept great, and some people do, and that's great, but just managing expectations for what's involved with this. Okay. Unfortunately, I think I'm getting to the end of my time here. I have some information, and Inspire has a nice program and protocol for people who are doing this in their own practices already and seeing these patients back for their follow-ups and fine-tuning, kind of a protocol to follow as to, okay, the person who comes in and they're using it every night and they feel great and their wife says they're not snoring, super. Get them in the sleep lab, do their titration, see how their numbers are, and you can just do your routine follow-up. I usually see people every 6 months, or a couple of my people I'm doing once a year now. For your people who aren't doing well, whether that's because they're uncomfortable with the stimulation or they're still snoring or having witness pauses, there are a lot of things that you can do with the stimulation protocols, and it can be quite dramatic. The differences you can see in the movement of the tongue with some of the different protocols. I usually would have people come in if it's more of a comfort thing and do just some adjustments in the office and have them try it, have my nurse call them in a couple weeks. They might come back and forth a few times. If they're having problems with continued snoring or witnessed apneas, I'll usually do an office endoscopy and activate the device and see what settings does it look like we get the best movement of the tongue without making the patient uncomfortable. Ultimately, all these patients, I want to see them in the sleep lab for a sleep study with their device to get an idea about how well we're doing. And then some patients we might consider adjunctive therapy, whether that's positional therapy using an oral appliance or CPAP with their Inspire. I do have one patient who's trying that, and or additional surgical options. In terms of things on the horizon, we touched already on the bilateral hypoglossal nerve stimulator implantation. That's, this Nyxoah company with the Genio device is working on that. I know another one of our presenters is going to talk about Down syndrome today. I'm looking forward to that talk. That has been looked at in children. I have implanted 2 individuals with Down syndrome, adults, who've done very well, but looking at doing that in children. Bluetooth remote monitoring, I'm really looking forward to that happening. I have a lot of patients who are in the UP, and coming down to Green Bay is a big hassle for them, and if we could do it remotely, it would be great. And then one other thing I want to comment about this. The FDA, Inspire has applied for and gotten labeling from the FDA of a breakthrough medical device. And that is currently in the works of looking at increasing the BMI indications and the AHI indications. So hopefully we got to these questions for people. And I have some contact information from me. I think, do I have time, Marla, for a couple questions? Yes. Okay, I'll take a couple questions. I'll be here all day. And if not, feel free to contact me too.
Hey, just a real quick clarification on the MRI.
Uh-huh.
It's full body MRI at 1.5 now, and that goes back retroactively to 2018 for the device.
So any of the 3028 devices?
Correct.
Okay.
So it's full body. It was conditional with head and extremities.
Yeah. Okay. My bad. Thank you. Thank you.
We did have an online question, and it is, does the hypoglossal stimulation strengthen the muscles over time?
Not that I'm aware of. Not that I'm aware of that anybody has looked at. I think people have looked at, does the tongue look bigger? Do the muscles look to be hypertrophied? It's a really interesting question because if you looked back at the 3 and 5 year follow-up data from the STAR trial participants, you know, the decrease in apnea-hypopnea index went from 29 to 9 at 1 year, and then at 3 years and 5 years it was 6. And so what happened, you know, there? Why was it better? A little bit better. Maybe that, you know, maybe the muscles got stronger. I don't know. Good question, but I don't know the answer to that. Tracy?
Are you still seeing some behavioral modification issues with turning the device on before they fall asleep? You know,
Yeah.
my partner doesn't want me to use it. I mean, those kinds of things.
Yeah.
With CPAP.
I have a bunch of interesting stories about that, but I think that as an office, we've gotten a little bit better on prepping patients. Like I'll diverge for just a minute. I had a very nice older couple who got their device activated, went home. He woke up, forgot to turn it off, was having breakfast, and his wife was like, "Your speech doesn't sound right. I think you're having a stroke." Took him to the emergency room. He got a head CT, he got a neurology evaluation. While he was there, the 8-hour period that we have it shut off automatically shut off and his symptoms resolved. We're like, well, maybe this is a TIA, I don't know. You know, got started on aspirin, went next morning, same thing happened. They're back in the car going back to the emergency room and he says, wait a minute, I didn't turn my device off. And that's what it was. And I also have a really cute video of the very first guy implanted. Usually we set it for 30 minutes to start working to let people fall asleep with the device off. But the first gentleman said, I fall asleep fine, just make it 0. And because his wife was like, he watches the brewer as he falls asleep, he's snoring like a freight train. And so she took a video of him asleep snoring in his recliner, and his daughter comes over with his remote control and turns it on and the snoring stops. It was kind of neat, but anyways, I think we've gotten a little better about prepping patients for that. Yes?
I was just curious about an implanted AED.
Yeah, so I've not, you can do it. I've implanted several patients with AEDs, pacemakers, spinal stimulators. I haven't found a device yet that I've called the Inspire engineers that they've said can't do it. So as far as I know, yeah, okay.
All right. Thank
Thanks,
you so
everybody.
much.